Well, it's been a big day for policy already today. We've had the Gordon-Brown National 5-Year Plan, or whatever it's called, announced. I spoke to Andrew about it, and you'll be surprised to hear he wasn't that impressed, which I was surprised. I thought he'd say to me, oh, thank goodness at last, a really, really good health policy from the government, but what could you say? Now, much of health policy is concerned with service provision, aiming to raise standards of care, cut waiting lists, and encourage efficiency, but there's a growing realisation that we need also to understand how the users of these services think and behave if better health outcomes are to be achieved. I think I'm right in saying that apart from population ageing, the greatest driver of growing health demands on the health service relate to people's lifestyles. So those are the kinds of issues we'll be discussing today. Behaviour, choice and health outcomes is the kind of terrain that our speakers will be walking over in their comments and in the conversation we'll have after that. This project has come out of a project we're undertaking here called the Social Brain, which aims to produce a more realistic and grounded understanding of how people behave, how they make decisions, based on the wealth of new research that's around from neuroscience, behavioural economics, social psychology, anthropology, ethnography, trying to pull all that together to develop a kind of usable model of how people make decisions of human behaviour, which will be of value to practitioners. So this is an important part of that kind of discussion. Our panel will discuss the development of strategies which allow us to make better choices about our healthcare. Our four speakers for tonight are Paul Dolan, Theresa Marteau, Ben Seymour and Andrew Lansley. I'm going to say one sentence about each. I could, of course, speak volumes about their distinguished careers, but I'm just going to do one sentence about each as I introduce them. They will each speak for about 10 minutes. Is that what you've been told? Yeah. And then we'll open it. Ordered, good, yeah. And then we'll have time for questions before we wrap up at 7:15 on the dot. So our first speaker, who I'm sure if his previous appearances here are anything to go by, will be very provocative and engaging, is Paul Dolan, Professor of Economics at Imperial College. He's held academic appointments at the universities of York, Newcastle and Sheffield, where he founded and directed the Centre for Wellbeing in Public Policy.
Once upon a time, psychology thought about changing behaviour by essentially changing the person. If I can change your beliefs, your attitudes, your goals, then you'll change the way you act. So that's psychology done. Economics talks about, I said it a bit quick, talks about changing incentives. We don't inquire into your preferences. We don't really want to know much about those. We don't try and change the person you are, but we change the incentives that you face. If I change the price of bad things, then you buy less bad things. And by and large, those models and theories, and there are many models and theories within each of those areas, operate on your, and I'm going to be incredibly crude to the neuroscientists now who are coming up next. So this is neuroscience done in about as much time as I've done economics and psychology. This is a brilliant class. You've got two bits of your brain. You have the prefrontal cortex bit, which is your rational, logical, thinking self. This is the bit that makes us special. And the psychologists and economics to a large degree operate on changing or affecting or influencing the way that you think and therefore the way you act. I'm not going to talk about any of that. Many people have spent a lot of time talking about much of those things. I'm going to talk about the bit of your brain that is not special, the bit of your brain that you share with every other animal, reptile, and everything else that I can't think of, is your automatic system. This is your limbic system, the bit that sits right in the core of your brain. This is not your Dr. Spock, this is your Homer Simpson. You know, maybe Homer Simpson's not quite the right term, but it's your automatic self. One other thing I've been asked to do, I've been asked to stand still during this talk, which is very, very hard for me. So I've got my hands placed firmly on here. If you think I'm a bit kind of crazy, that's why, so that I don't move. I'm going to talk about your automatic system because it's remarkable, as you start reading more and more of this evidence, how much environmental factors, situation, context, affects the way we act. You know, you think you're a person who is a free will, and you act according to your underlying preferences and goals, beliefs and attitudes. No, you don't. You're incredibly affected by the situation. It has a much greater effect on individual action than we'd ever thought before. And there's a quote from the Nobel Prize-winning psychologist, who has a Nobel Prize in economics, who I had the privilege of working with in Princeton in 2004 and 5. Now, our model of individual behaviour is captured by the following acronym, SNAP. It does exactly what it says on the tin. It's a way of behaving according to your automatic self, without consideration, without thought. And SNAP stands for salience, norms, affect, and priming. You can see from this slide what they mean, and as I say, those terms also should be quite self-explanatory. I'm not going to spend, I don't have time to go through all of these elements, but just quickly to say exactly what it says on the slide. We attend to things that are novel and new, and not things that are old and established, and we attend to things that we understand, not things that we find complicated. Norms are, you know, we take our cues from what other people do. Affect is basically psychological speak for feelings. We act based upon our feelings, not only on this kind of rational, sensible self, if you like. And priming, we respond subconsciously to stimuli. Let me just give a couple of examples of how SNAP, or different elements of SNAP work. And I think once more, I don't have time to go through all of these, but let me just give 2 examples. Let me deal with the N and the P of SNAP. Bob Cialdini, who is a social psychologist in the US, has done a number of experiments in a number of different ways, testing the effect of norms on individual behaviour. In one classic study, he got a hotel chain and the chambermaids within that hotel chain to count up the reuse of the towels in the hotel rooms based upon the signs that were placed in the bathroom. If you say to people, please reuse your towels because you save the planet, you don't get very many people reusing their towels. If you say, please reuse your towels because people who stay in this hotel chain reuse their towels, you get more people reusing your towels. If you say, please reuse your towels because the person who stayed in the room before you reused your towels, then you get a significant increase in towel reuse. Why? Because the person who stayed in the room before you is in some ways like you, and you want to be like them. That's a norm, it's a cue. It's a way to affect your behaviour, not by changing your preferences, or not by changing your incentives in any kind of strict economic sense. It changes the way you behave because you want to join a club, and you want to join a club of people like you. So it is rather perverse that we have messages like 30% of people are obese and overweight. A much more effective message would be 70% of people aren't. Priming. Well, priming is probably my favourite example at the moment, because it's the most automatic influence on our behaviour, because we're not even aware it's happening. If any of you are overweight and you want to lose weight, very simple thing to do, go home tonight, smash all your plates up and buy smaller ones. Thank you, it was a laugh. Actually, I wasn't being funny then, but thanks anyway. So, yeah. I'll let you know when I'm being funny. The reduction of plate sizes from 12 inches to 10 inches reduced calories consumed in one study in the US by 22%. Why? Because, well, you just fill your plate up to when it's full. You don't think about how big the plate is and fill it up according to how big the plate is. It's a classic priming. As I say, priming is my favourite example at the moment. Let me give another example of how these effects work. Many studies now, different contexts, different areas, different applications, showing the powerful effect that cash has on individual behaviour when you prime money. Let me give you just one of these examples. I put students, mostly these samples are on students, I'll have something to say about that in a second. Put one group of students in a room where they have a screensaver flashed in front of them of money. Place another group of students in a room where they have fish as the screensaver. Walk into the 2 rooms and drop pencils on the floor as if by accident. and then count up how many pencils you're helped with by the students in the 2 rooms. Students who are primed with cash pick up significantly fewer pencils. They help you less. This idiot has been stupid enough to drop these pencils. Why the hell should I help him? Because cash is ostensibly a self-interested, selfish prime. Now, the students are not aware that they're picking up fewer pencils when they're primed with cash, but they do, and it can affect behaviour. And so this is very much, all of this is very much in keeping with the language of Thaler and Sunstein about choice architecture. The way you shape the environment is not neutral in its effects on us. And therefore we have a say in, as choice architects, over what the choice architecture looks like. One of the things that we now need to start doing more of, since we know that priming has such an effect, and norms and affect and salience matters, in student populations, in experiments, in labs, is we need field experiments. We need proper RCT type design, randomised trials, that look at the effect of these elements of the choice architecture in a real world setting, because that's of course where we act most of the time. So let me give you one example that we're doing at the moment. We're involved, I should say that this is work that I'm working on with a host of people whose I haven't got time to go through all their names, but there are 2 people sitting in the audience, so I have to say their names. The psychologist Ivo Vlejev and the surgeon Dominic King. We are working on a study that's looking at priming about gel use in hospitals, where we are going to literally be able to observe how much gel's used by which people when we give them different primes. And one of the primes will be a nice clean smell, because we have evidence that people who are given a clean smell prime are tidier, and we want to see whether it makes them cleaner. We know that if you put eyes above an honesty box, people pay for their coffee and their donuts more than if there are not eyes looking down at them. So we will put some eyes above the gel and see whether this increases gel use. What we will be able to do is to see whether these effects are sustainable, because that's something that we don't have a considerable amount of evidence on at the moment. We know they work and tweaked, but we don't know whether they work over the long term in a natural setting. We need more field experiments is a general academic plea from me. We can do much more than we do at the moment in natural settings. My conclusion, although it's not a concluding slide as such, is that you need to place this in the appropriate context, of course. You need, at some level, of course, I mean, priming works because we're not aware that priming works, but you need to make people aware that we might be priming them. So we need public buy-in to these kinds of interventions. We know the environment affects behaviour, therefore we need to choose the right environmental interventions, but subject to having public buy-in. And no one wants to be charged with a nanny state, do they, Andrew? That's a terrible charge that anybody could have. It's probably the worst thing you could ever be called as a politician right now. Or no, I'm sure there's worse. And I was going to, that was going to be my final slide. It was a perfect point at which to stop with the woman's mouth taped up, and I was going to say you can tape my mouth up, but I moved one of my earlier slides to last. And we need to place all of this individual behaviour change, because that's what I've just spent the last 10 minutes on, in the appropriate social context, as I've just said, but also in joining up change to bring about the most effective changes in individual behaviour. It's when you join up institutional change, cultural change, moral change, legal change, and individual behaviour that you bring about the most effective and cost-effective changes in individual behaviour. And on that note, I shall say thank you and shut up.
I want to address 2 questions. Why is it that, despite placing a high value on our health, the majority of us behave in ways that undermine our health? I think, actually, Paul, it's estimated that around 60% of people are overweight and obese, not 30%, so it's the majority. Secondly, starting with valid models of human behaviour, what are going to be effective and acceptable ways of trying to intervene? So, in addressing the first question, really touching again on what Paul's already mentioned, we can think of human behaviour as being a function of 2 systems that interact. A reflective system, which is driven by decisions, people's values and also their goals influence their behaviour. So, for instance, someone thinking that losing weight is a good idea will generate an intention to do that and engage in behaviour to avoid dessert by leaving the room. So, with the reflective system, there is an idea of a future, there's an idea of a goal, and it requires a deal of cognitive capacity. By contrast, the impulsive system, which is operating in parallel, is cued much more by the environment. So dessert appears, someone has a positive disposition to eating dessert, and before they know it, they've consumed the dessert. So future isn't represented, it's very immediate, it's very fast, and your vice is your virtue needs almost no cognitive capacity to engage in behaviour through the impulsive system. It's important that we do have both those systems, though, because we have limited cognitive capacity. So if every morning you decided to take a different route to work, all your cognitive capacity would be spent on trying to work out which buses to take, as opposed to travelling in an automatic way, which leaves you free to daydream or read another paper or even write another paper. So there's an advantage to having the two systems, the impulsive system. When it comes to health-related behaviour, much of our behaviour is habitual and is cued by environment, so it's working with the impulsive system. And yet, most of us think that our behaviour is largely a function of our reflective system, but in truth, it's largely a function of the impulsive system. And this is termed the fundamental attribution error, which psychologists have been studying for some decades now. And it's an error to which politicians, as well as policymakers, and indeed the rest of us, are subject to. So, in answering my first question, why do people behave in ways that undermine their health despite placing a high value on health? First of all, our behaviour reflects two systems, but the impulsive system dominates. And as I've already mentioned, that's the system where values and the future don't feature very highly. So it's not that people are being irrational, it's just their behaviour is being influenced by a system that doesn't relate terribly well to the future. So given all this, what are effective and acceptable ways of trying to intervene? Well, governments and others have at their disposal a large number of ways of attempting to change people's behaviour. And this is a ladder which is adapted from Nuffield Council on Bioethics report on public health and ethical issues. So if we start down the bottom, providing information, very often that's seen as one of the more acceptable ways of trying to influence people's behaviour, and very much feeds into the reflective system. And some say that this very much is in accord with J.S. Mill's ideas of liberty, whereby you're helping people to make decisions, giving them information, it's their choice, and you only intervene if there's harm for others. The problem is that this is one of the most ineffective ways of trying to change habitual behaviour. So as a result of that, people have gone up this ladder, if you like, and looked at other ways of trying to change behaviour. So looking at changing the environment, changing defaults or restricting choice. So, for example, recent tobacco legislation, so restricting where people can smoke cigarettes, or by changing the immediate consequences of behaviour. So either by offering positive financial incentives or by disincentive through taxation. And these are interventions that speak much more to the impulsive system and have been popularised through Thaler and Stunstein's recent work on nudge. So, as Paul's already mentioned, nudges are changes in the way environments are presented, choice architecture, to make it more likely that people behave in ways that, upon reflection, they prefer. Okay? So it's trying to dodge around your impulsive system to ensure that you're acting much more in line with your reflective system. Now, there's great potential here, as we've already heard, but the problem is that people are concerned that maybe we're going to confuse nudges with shoves, and it becomes very important to disentangle them because, as I say, there is great potential in terms of changing population behaviour, as we've already heard, by changing the size of dinner plates. But equally, we don't want people to hijack those interventions by saying that that's a shove. And similarly, we don't want to be in a position where we are shoving, overriding people's freedoms, misguidedly thinking it's a nudge. So we can start from this as a simple definition that nudges increase the chances that people act in ways that upon reflection they most desire, whereas a shove is increasing the chances that people act in ways that are preferred by the shover but not the shoved. So if you're a policymaker, how do you begin to make sense of that? Well, one very simple way is perhaps looking at the proportion of a population who say they want to change their behaviour. So we know that around 70–75% of smokers want to stop smoking at any one time. Around 75% of those who are overweight or obese want not to be in that state. We also know, most recent data, that fewer than 20% of the general population who consume alcohol want to drink less. Okay? So, if we look at this, we might think that, is it acceptable that any intervention that's targeting making smoking or giving up smoking easier, making losing weight easier, could be seen as a nudge, whereas any attempt to try to reduce drinking in our population would be seen as a shove? So I think that in part explains why people were so negative about the recent policy about the minimum price per unit of alcohol. People were experiencing that as a shove. But equally, would it mean, if we're thinking about, say, smoking, or just offering people, or rather one particular idea that was floated by Julian Legrand was perhaps all smokers should be purchasing permits, and they'd have to make a decision, go in and exchange money before they'd be allowed to buy cigarettes, losing weight, reduce the number of fast food outlets. Should there only be one per square mile? I mean, where does one stop? So at the bottom line here is that more conceptual and empirical work is needed to develop sensitive methods of being able to actually determine what are people's preferred preferences and what actions, what policies would actually be deemed acceptable as a nudge and not a shove.
So I'm going to argue that in many ways we're inherently poor consumers of health. As patients, we're inherently bad consumers, not because we're ill-informed, not because we're stupid, but because of a natural consequence of the way that decision-making works in the brain. Now, as a neuroscientist, I study how the brain makes decisions. And neuroscience has recently revolutionized our understanding of decision-making in the brain. And it's started to build a new economics, and a new economics based not on how we think people should behave, but how people actually do behave. And this new field, which we sometimes call neuroeconomics, has allowed us to see whether a traditional model of economics is wrong, and allowed us to make predictions about where the new model diverges from the old model. And if there's one area where we predict there should be that divergence, it's probably going to be health. So of course, it's not particularly new to suggest that people are inherently, we have an inherent tendency to make irrational decisions. But there are a few critical areas where we predicted these irrationalities should have particular problems in health. The first of these is the avoidance paradox. So this arises from the fact that health is something that we'd inherently rather not have. It's something we'd inherently choose to avoid rather than choose to have. So in a sense, health is an inhibitory product. And this means you've got no way of knowing whether, whether the product you choose is actually necessary. You've got no way of knowing whether it's not excessive. And it's inhibitory because of the fact that it represents the absence of a state that you'd rather not have. So that means it's very difficult to make rational choices about health. And the problem is one of information. The only way to get more information is to make bad decisions and explore the value of their ill health so that you know how good your decisions actually are. So the sort of natural paradox then is that we need to make bad decisions so that we know how to make good decisions. So the second problem is what we call the optimism bias, and this arises from the fact that the actual state of anticipating ill health is inherently aversive. So imagine that you're going to the dentist, and the dentist says to you, well, you can either have your tooth out now, or you can have it out in a week's time. So most of us choose to have it out, have it out now, which is contrary to the predictions of economics, because we don't want to have to go through the process of worrying about it for the next week. We don't want the dread of anticipating it. And that means that we're inherently averse to thinking about states of ill health. Now, of course, the corollary is that we enjoy thinking about things which are nice for us. We enjoy thinking about rewards. But the critical consequence of this is that we spend far too much time thinking about good things in our lives and far too little time thinking about potentially aversive things. So that sounds like a bad thing, and of course it is. But it gives us this difference between good and bad. It gives us our sense of optimism. And optimism is a key ingredient to our sense of well-being. So give people choice, give them control, and they are happier, but they necessarily make worse decisions. So the third problem stems from our capacity for regret, or more particularly our desire to avoid future regret. And it comes because we're inherently averse to making the wrong decision. And that comes because of the natural consequences of the way that the brain computes future outcomes. This is a great curse of agency. And that's why people often say in a restaurant will choose a tasting menu over the a la carte menu, even though many of the same dishes appear on both menus. What we don't want to do is look at the table next to us and see that somebody's ordered a dish that we wanted. The burden of choice is something we want lifted to us, and of course in a restaurant we give that burden of choice to the chef. But of course when it comes to health, regret can cause us to make irrational decisions, or worse still, it can cause us to avoid making decisions. And the trouble is, if we make bad decisions, if we make decisions that we regret, that then exacerbates the problem the next time. And there's no easy solution to this. What we need to be able to do, if we want to preserve choice, is to be able to choose not to choose, as it were, to take the chef's menu. Now, in a sense, these top three problems are casualties of the inherent structure, the inherent architecture of decision-making in our brain. But if we set those aside for a minute and ask how good are we actually at determining how good or bad states of ill health or health are, how good are we at deciding, what the actual worth of a state of health or ill health is? And this is critically important. This is a fundamental assumption of efficient markets hypotheses. This is a fundamental assumption of a consumer-driven healthcare market, is that we know what we like, we know what we want, and we know what we don't want. But the sort of niggling problem has been that when it comes to neuroscience, no such sort of inherent, no such intrinsic value scales have ever been found in the brain. So we can study these. We can design experimental healthcare markets and see how people behave when they've got to essentially buy health products. And we do that, for instance, by having a model for ill health being delivering painful stimuli to the arm, and then giving people money and asking them to buy their way out of it. And to cut to the point, the remarkable thing we find is that people appear to be inherently bad at making stable, absolute valuations of how much pain, for instance, is actually worth. We appear to have no absolute scale for this. But what we are good at is making comparative judgments. We're very good at saying that pain A is worse than pain B. We're very good at saying we'd rather pay more for or less for a particular relief of pain. And this is important because it means that markets shouldn't behave in the way that we expect, based on the traditional assumptions of efficient markets hypotheses. And it means that we can push behavior all over the place. If we maliciously seed anchors which force people to refer to prices that are unrealistic, people are easily guided by these. Okay, so what does neuroscience predict for health and decision-making? Well, what I've tried to say is that it suggests that we should be inherently cautious about using patient choice to drive efficiency and to drive quality improvements in healthcare markets. Some of these rationalities are not just basic rationalities, they're irrationalities which are, in a sense, persistent and pernicious in decision-making. Perhaps more importantly, it also suggests that patients should be very vulnerable to health care providers whose incentives are not the same as the patient's. But on the positive side, if we can understand the decision-making architecture, then we can design choice architectures which enable people to make better decisions about their health. so we can encourage people, whilst maintaining choice, to make better decisions about various aspects of their lives. And, of course, one man's irrationality is another man's opportunity, and this is well known in marketing. So perhaps we need to think about health not as cold clinicians, but more as marketing or advertising executives, and start to use all the tools that are used in advertising to help sell health in a much more efficient way. And after all, if advertisers can sell you things you don't need, that you don't want, that you can't afford, how much better should we be able to, as policy makers, be able to sell health for something which is inherently good for you? So my argument is for choice. We need choice to give people control. We need choice to give people a sense of well-being. And importantly, we need choice to give people responsibility. But choice on its own is insufficient. We need to be able to sometimes choose when not to choose. So my argument is also for paternalism. We need paternalism to help people who are vulnerable to both themselves and to unscrupulous providers. And paternalism is not about restricting. It's not about controlling, but it's about protecting patients. It's about caring for patients, and it's about enabling patients to make the most of their information. Thanks.
When thinking about how we are going to deliver improving health outcomes for the longer term, there are two things that I know I should talk about that are absolutely instrumental to that, but I'm just going to tell you they're important and then move on. The first is that there has to be a clear long-term strategy for public health organisation, structure and financing that we haven't had. It needs to be established that there is a cross-government, including between government, the NHS locally and local government, with resources to support it, dedicated resources to support it, and in circumstances like those that we are currently anticipating, that the requirements of day-to-day treatment on the part of the NHS is not going to close out public health initiatives of a long-term character as they have done in the past. So we're very clear that needs to happen. Hasn't happened in the past, needs to happen. Second thing about being long-term is that we have to move from short-term initiatives that are not evaluated, not piloted, not evaluated, not subsequently reported on and then rolled out properly. We've got to have proper strategies that are properly evaluated and are then persisted with, rather than all this short-termism. I mean, we've been through health action zones, healthy teachers, healthy living centres, the Young and Active campaign of 1998, Wired for Health in 1999. We had the Healthy Workplaces Initiative in 2006. In 2006, we had small change, big difference. Nothing much happened. There wasn't a big difference. We've had healthy further education. We had healthy towns. Alan Johnson announced healthy towns. They seem to have disappeared. We had healthy weight, healthy lives. We have to be willing to persist. Now, we may, to some extent, and here I recognise there are many, perhaps in this audience, who know the importance of research. And it will know, in the public health context, the importance of moving from research which is analytical, the nature of the problem, to research which gives us good evidence about the effectiveness of interventions. And I know we need a lot more of that. We've had 99% analysis of the problem, 1% analysis of the solutions. But we can't allow analysis to be a substitute for action. We are going to have to take action. So I'll just make it clear that from my point of view, there are a number of initiatives that are presently underway which it is important for us to establish as part of a long-term strategy. So, for example, where Change for Life is concerned, I've said before, I'll say again, we have a brand in the making that it is important that we use and sustain for the longer term to be at the heart of our social marketing campaign with the public so that they can use it to take greater responsibility for their lives. But does that mean Change for Life won't change in advertising and marketing terms? No, it doesn't mean that, because of course it will have to adapt and it will have to respond to the emerging evidence, not only of brand awareness, but what people understand to be the characteristics of what they should do about Change for Life. Because if it is a social marketing campaign, Ben, if it's advertising, actually it can't persuade people to buy something they don't need and don't want. I mean, in advertising terms, let me just give you two examples. Ford Edsel and New Coke. These were campaigns that went out there in order to persuade people that the thing they didn't want and they didn't need was the thing they were going to go to buy. And lo and behold, millions of pounds were spent and people didn't buy them. Now, I think where health is concerned, I mean, the government published a document called Healthy Choices, and one of the perfectly reasonable reactions to this was to say, well, who is choosing to be unhealthy? It isn't really like that. The point is, tomorrow morning, and I don't normally advertise on behalf of the Daily Mail, but have a look at the Daily Mail tomorrow morning. I think Tuesday morning is the morning when the Daily Mail generally provides about 17 pages of health. Now, you might argue, well, an awful lot of that is health scares and health this and that and the other, but actually most of it is, how can I be healthier? Quite a lot of it is public health. It's about lifestyle choice, about diet, about treatment and so on. There's probably going to be 7 pages of politics and 17 pages of how to be healthier. So my presumption is people would like to be healthier. The point is we have to help them to do it. We have to help them to make this happen. And I think one of the fundamental misses in the past, if you go back to Theresa very helpfully, I'd almost like to put it back up there if we can't do that, but if you think back to the Nuffield Council on Bioethics and the intervention ladder that they published 18 months or so ago, I think it's very helpful for thinking about this, because government has tended only to operate at the two ends. Where smoking was concerned, the conventional public health response has been to say, well, if you're impinging on somebody else's health, we are going to step in and stop you. It's like with drinking, actually the government's attitude is, if you are going to get yourself blind drunk and start hitting people with bottles, we're going to stop you. That's at that level of intervention. The other level of intervention is right at the other end, providing information. So for where drinking is concerned, is saying, well, we're going to make sure that children know how many units of alcohol there is in a bottle of cider. Well, I have messages for the government that, because I went with an alcohol charity in Nottingham 4 years ago, and they were, as a charity, they wanted to go out and to talk to children in schools about alcohol, the effects of alcohol, the impact of alcohol on them and the choices they make. And they said when they first did this a few years ago, they were very surprised. Perhaps they shouldn't have been, but they were very surprised, because actually they found that 11 and 12-year-olds had a great deal of information about how many units of alcohol there were in different kinds of drinks. Not because they wanted to reduce the abuse, but because they wanted to maximise the abuse of drinking. So information is not enough. So there's an enormous territory, I think, as Theresa was intending to demonstrate, there's an enormous territory between legislation and regulation on the one hand, and information and no more than that on the other. And it's that territory we have to move into in a much stronger fashion. Now, there are a number of routes to this. One, Matthew will forgive me, but I'm not in a position to say exactly what's in it, but shortly we will be publishing. In fact, I won't. When I made a speech about our attitude to public health last August, I described it as no nannying, no excuses, meaning that we shouldn't, because it is counterproductive with adults in particular, to be seen to be nannying them about what they should do. Their reaction very often is simply to switch us off. The no excuses, however, is once we have equipped people with information and responsibility and an idea of what it is, the benefits from making positive decisions about their lifestyle, then actually we have to also say, and you do have this responsibility. You can't hand it over to government. And that's the no excuses. But there's an awful lot we have to do on the no excuses side. And what that speech was designed to lead into, which has in the intervening months has happened, is there is a team led by Dave Lewis from Unilever UK, which includes people from charities, Diabetes UK and the British Heart Foundation, from businesses, from stakeholders, people like the British Nutrition Foundation, so on, who have got together and have said, let's put aside the things that we disagree about. Let's try and devise a programme of action that will enable us on the issues of obesity, of responsible drinking and of occupational health to bring forward proposals which enable us to have this kind of strategy, whether it's reformulation of foods or labelling or bringing together social marketing campaigns, getting the messaging right, all the way through to trying to work in workplaces with small and medium-sized employers. And they will be reporting shortly. and that is an important component of what we're trying to do. But it isn't the only component, and because I want to emphasise that from my point of view and our view as a party, we are convinced that in order for this to work, including that responsibility deal to work, with all those changes in things like formulation of foods and so on. I mean, I think Paul said at the outset, you know, the smaller plates and so on. Well, things like portion size, it's in there, it's part of it. But in truth, we are going to find it intensely difficult in a free society with free consumers to stop businesses and commercial organisations giving people what they want and securing commercial advantage. Now, we are going to try and harness corporate social responsibility together with government and the voluntary sector in a combined operation. But actually, fundamentally, we do need people to take greater responsibility.